Okay, this is a very important session. I'm glad you all are here, glad you're on out at the other campuses. Just to say, we're at a pivotal point, I think, with patient satisfaction, patient experience, if you will. So what you're going to hear today, I hope you're going to take to heart, know that this is on us, guys. You hear Dr. Jackson say all the time, well, it's on the nurses' backs. Everybody needs to be a part of it, but we all know that we're the touch point for everything that happens with our patients. So it's very important. It's very critical. You know, it doesn't matter to me if you take notes or whatever, just so it gets right in here and right in here, in the heart and the head. Mind to know this is what we need to do, and these are our marching orders, and we need to really make sure that we're putting it first and foremost on our agenda, our daily agenda. Okay, I'm going to let Ted, are you going to introduce? Okay, I'm going to let Ted introduce our guests, and we know that we have a hard stop at 9:30 because several have to leave for another meeting, so we'll just make the best of that. Okay, thank you.
So we have Mary Jo Ossie.
That's correct.
And she's Senior Vice President, Clinical Excellence Solutions Associate Chief Nursing Officer for Press Ganey. So thanks for coming in.
Sure thing. Hi, good morning, everyone. And thanks for having me here today. So first and foremost, I'll just let you know a little bit about my background. I've been a nurse for, 40 years and a few. Okay, so I started when I was 3, so that explains why I look so youthful. But anyway, I've been a nurse a long time. So, you know, like many of you, okay, you've seen different variations, cycles. Everybody's seen cycles in nursing. Things come through. We have shortages. We have burnout. We have things that we're talking about, you know, like our entire way through. And in the 90s or so, around there, patient experience became a very big deal because we started to really understand better what happens with our patient in that context and how it influences RN engagement and satisfaction, how it influences outcomes. And I'm going to kind of go through and show you some big data, you know, to sort of understand why we look at data in the first place. I will start by saying right out, okay, you're going to see some data slides here, but that's not really the focus of this presentation, all right, because I'll tell you right now, we use data, and I'm from a data, you know, I work at a data company, Press Ganey, okay, and I can tell you, and everybody else at Press Ganey will tell you, we understand that you're using the data to guide, okay, and tell you how you're doing. It's really used as a guide. That's not the point of this presentation, but we will use it to highlight and emphasize some of what we're talking about here today. And hopefully by the end of the presentation, it will connect some dots for you in terms of why we look at this in the first place. So, get this to go. She said it's not working too. Oh, okay. So our challenge and our responsibility, and this fits in pretty much in any healthcare organization we go, is to deliver safe, high-quality, patient-centered care, okay, which kind of when you add those together is what we kind of define as the patient experience. And then you'll see underneath that, foundationally, okay, making sure that we have engaged and resilient care teams. Does anybody doubt, okay, that it's pretty much impossible to make the strides that you want to make if you have a disengaged workforce or a burnout workforce? Okay, nurses, everybody. All right, does that kind of ping with you? I mean, have you been in a situation where you've worked with colleagues, really, where there's a lot of disengagement? Because we all go through cycles, different jobs. You know, it could be here, it could be somewhere else, it could be on one unit that changes over time. We go through cycles. And so when you're in that situation, you know it. And when you're in a situation where you have highly engaged staff, okay, nurses and so forth, you also know it. Those are some of your best experiences in nursing. Obviously, it's the latter that we're trying to make sure we get to. But that foundational piece on engaged and resilient work teams, care teams, you're going to hear me refer back to because it is so critically important to being able to achieve all the rest of this. And so, sorry for the eye chart. It's pretty, though, wouldn't you say? It's very lovely, okay? But actually, somebody put a lot of thought and work into putting together in the last year or two where Press Ganey has moved prior to 2012 to now. Prior to 2012, you know, I was a nurse, you know, in healthcare and hospitals for 35 years. And I was on the other side of this as a Magna Program Director, working as Director of Professional Practice, and other roles that I was in, okay, to be looking at the data and trying to understand, like, what does it all mean. And prior to 2012, we called Press Ganey sometimes. That was client in 2 organizations. And we got very brilliant statisticians on the phone who didn't really ever had never really worked in healthcare and didn't really understand, you know, that whole environment. And so what happens is the conversation, there's a gap there. After 2012, there was a change in senior leadership with Pat Ryan and Joe Groscoviac. Pat is now, I think, is he the executive director? Anyway, he was the CEO and has moved into an executive director chair, and Joe Groscoviac is our CEO. They came from healthcare. And so they understood the importance of when you give somebody a lot of data, okay, do you get a lot of data coming your way ever? Any day? Every day? All right, and how does it feel when it comes to you just en masse? All right, does it feel like, what is your next question? What do I do with it all? Okay, there's so much data coming. How do I focus my efforts and what do I do? And so they realized that really, in terms of Press Ganey becoming much more of a partner with organizations, we needed to understand, okay, how to help and partner with our clients, okay, and our organizations, our healthcare organizations, on what to do with the data. And so they started really restructuring all of their leadership, hired a lot of people, okay, in thought leadership that come out of clinical practice, including myself and Christy Dempsey, our chief nursing officer, many years of clinical practice to help bridge that gap. And that's what we're going to be talking about and doing here today. Now, when we started really heavily into quality improvement, anybody remember the 80s and 90s? Now, I don't want to date myself, but I already did. Okay, so the 80s and 90s, okay? You know, remember when the quality improvement really started to take traction and hold? Anybody remember core measures when they came up? Okay, so we've been through an evolution, okay, in the quality improvement area, and so these boxes on the left are meant to really display where a lot of organizations started, and some still remain, in terms of how they think about data. And so if you look at, you know, the 4 domains that we really pay attention to on the right here, safety, clinical excellence, workforce and engagement, and patient experience, that really does do a big 360 in terms of what happens in healthcare. And when you look at these correlating boxes, you can start to see where we have caps. And we've been in situations where we have one person that just looks at the CAP scores. Have you ever seen that anywhere? They just pay attention to that. And they come to nursing with ideas about interventions on how to improve not only CAPS, but on this one question, or 2 questions, or 3 questions. Okay, and then we have point of care, we have transparency, which is a new one coming up. Then we move over into engagement, and typically, or very often, it's human resources that has responsibility. And then they'll come back and they'll say, for nursing, this is what we want you to do. Okay, nurses, we need you to do this. And then we look at nursing, clinical measures, nursing database for nursing quality indicators, NDNQI, it's your pressure, else's falls, and so forth. Nursing excellence and RN engagement, which is our specific RN surveys, and we look at those and data comes back from those. All right, and then internally, we're also then looking at other things that we want to improve on. And then we see safety. Okay, there's a lot of safety, and sometimes that's handled by risk management. It may be handled by somebody else. So you start to get the picture of a lot of people working really hard to make improvements, but they've got data coming from all over. And a lot of them end up coming to nursing and say, we just need you to do this one thing. And how many things does that eventually turn into? Do you do more than 4 or 5 initiatives in your area? Anybody? Usually people are laughing hysterically by that time, saying more than 4 or 5. Sometimes it's 15 or 20, it feels like. And I can tell you, I came from an organization, when we started this in the 90s and early 2000s, where we looked at patient experience data, they put it out every day. Now, you want to talk about crazy making? Okay, people were like, they didn't know what to respond to because they weren't looking at trends over time. They weren't using the data the way that really it needed to be used, which is to guide. They were responding to every little thing. Hence, we had 20, 30 different initiatives, and the nurses were losing their minds, okay, trying to respond to all of this. And do you think that people can really respond to all of that? What happens? It's initiative fatigue, right? So that's the flavor of the month idea. Okay, so we're going to talk about how to maybe change the thinking around that a little bit for you to take away and consider today. But what we're looking for in this transformational slide, we're seeing more of this in the middle now, where all of patient experience is being considered together. So the key stakeholders across different domains are really working more together on PX, at least we hope so, and workforce and engagement and clinical excellence and safety, instead of it being siloed on the left. Ultimately, what we're looking at, okay, is moving to the far right. And we know it's a journey. It's a journey for us as well, okay? But when you move all the way to the right, okay, you're looking at all of your data and how one thing influences another. So all the people that work with all these different areas of data, basically in metaphorically and realistically speaking, are in the same room talking about data, okay, and how they want to focus their efforts so we're not duplicating efforts or even putting initiatives in place that conflict with one another. And so there's a lot of work to be done, but, you know, we're all on the journey. And so I think that that's a good way to kind of level set what we're talking about. And so when we talk about those things being integrated, I'm going to talk about some high level. Pretty much the next few slides are all from the national database for Press Ganey. So whether it's NDNQI or it's patient experience, enormous, massive database to show you the kinds of correlations. What we now do is we can look across those domains of safety, patient experience, clinical experience, and so forth. We can look across and start to do what we call cross-domain analytics. How do these things influence each other? And so we know that higher engagement scores are correlated to lower hospital-acquired infections and higher patient experience scores. We know that higher patient experience scores are correlated with fewer hospital-acquired conditions and readmissions. And we know that higher patient experience scores are also hitting the bottom line. We all have to pay attention to that. Got to keep the lights on, pay the bills, right? In order for us all to be employed in a healthy organization, we do have to pay attention to this. So we want to have shorter lengths of stays, appropriately, of course, higher net margins, lower spending, and higher reimbursements. And with higher patient experience scores, we see those correlations. So important to understand, you know, and start to think about these things all influence one another. And so we know that top engagement drives quality and safety, as does RN satisfaction and top patient experience. Okay, they all influence those quality and safety outcomes. And so this just gives you, and you'll get these slides back. So I'll send those to a PDF to Jan and Sharon so that they can send them out to you, so you don't have to take pictures or notes unless you want to. But you could start to see some of the granularity. Now we're looking at engagement and then correlating it with the NDNQI measures for CLABSI, okay, C diff rates and so forth, and length of stay. We start to do the same with our RN satisfaction out of NDNQI and our patient experience, okay? And you see all of them, okay, correlate with lower rates when we see high scores there. They're all correlated to those lower quality or the better quality outcomes, I should say. And again, physician engagement, RN practice environment, and employee engagement. Okay, this is how they impact patient experience scores. Okay, so we see that they influence one another, and that practice environment, okay, is specific to nursing through NDNQI. So NDNQI, one of the big differentiators, Press Ganey acquired NDNQI in 2014. One of the biggest differentiators is the way that RN satisfaction survey works. Very specific and very granular to the practice and work environment. Would you all agree that's an important thing that we have to pay attention to? And we'll talk about that as we go through a little bit in terms of some of the research papers that we've done. But that practice and work environment becomes, again, foundational to what we're trying to achieve. So, again, just a little bit of a difference, some slides, not to get crazy with the data, but just to really point out that when we have patient likelihood to recommend, okay, we see that correlated with RN job enjoyment. Not surprising to any of you. So, again, we get to that RN satisfaction engagement. We're not going to probably see some of those better patient experience scores with a disengaged staff. RN patient likelihood to recommend and RN likelihood to recommend that organization to neighbors, friends, family are correlated. So if the nurse is more likely to recommend the hospital, so is the patient. And just overall, in case we haven't kind of gotten home enough on that with the engagement piece, this is the difference in overall HCAHPS for the all-over employee engagement, so where we have all employee engagement. All right, we're able to look at that, and you can see the difference when you have top quartile, okay, engagement scores versus lower quartile, the difference in your HCAHPS across the board. So there is no doubt, okay, how strongly, okay, engagement of the workforce correlates with patient experience. So we really have to, I've been in organizations, the reason I emphasize this kind of from the start is we'll weave it the whole way through. I have been in organizations sometimes where I'll say, you know, we so much have to work on our patient experience. I'll say, well, we do want to talk about engagement. We're going to do engagement, but right now, we're going to get to that. Okay, but right now, we're going to focus on patient experience. And we can see from what the data does and how it guides us, we really can't ignore the engagement piece, okay, in favor of just trying to do initiatives for patient experience. We really have to look at both at the same time. And then NDNQI, basically this just tells you it's a very robust database that's specific to nursing, but I am here to tell you with that practice and work environment piece, practice and work environment is where the patient receives care, where the family receives care, and where clinicians provide care. And so while it's nurses that are answering those questions, okay, what comes out, the picture that it paints about the practice and work environment has a ripple effect to anybody who interacts in that area. Okay, so it has implications for physicians, for physical therapists, for anybody, okay, all of our techs, patient care techs, anybody who provides care in that area, okay, is influenced, even though it's nursing taking that. So I would ask you to keep that in mind, that practice and work environment piece, again, very important. And so nursing. So why do we focus on nursing? Nursing, it's an entire team, as Jan pointed out. And there is a lot that happens with nursing that makes it unique, okay, to the influence on the patient experience. But I'm here to, again, say to you, all right, when we think about nurse, okay, and what the patients are asking, they will answer questions about physicians that are physician-specific, and then who is the nurse in the mind of the patient? Everybody else. Okay, so while they're answering for the nurse, it really does mean the entire care team, because they don't have any way to answer those questions otherwise. And so Jan is absolutely correct. It is the entire team. However, nursing has a big leadership component in this to make it happen. And the reason for that is, again, being able to create, okay, and the people that are closest to that are the unit nurse managers, right, that are on those units, be able to create that healthy and positive work environment. Also, nurses make up the largest segment of the workforce and spend the most time with patients. So just by virtue, the unique nature of their role, they spend a lot of time with patients, okay? And they're interacting with patients in a way, okay, that does have a big influence on patient experience. And we know that extensive body of literature has supported the importance of a healthy work environment for many years and continues to do so. And so we achieve excellence by linking nurse data and nursing work environment. And so some of those things have shown, as has our data, the research that we've done, that HCAHPS scores across all domains respond favorably to better nurse work environments. And we have ways of rolling those questions up, okay, into like subscales or, you know, kind of indicators that tell us about the practice and work environment in different ways. And that's how we make those correlations, all right? Quality of care ratings are higher. Performance on value-based purchasing patient experience scores are higher, as are patient and nurse perceptions of the care quality, which is a very sensitive indicator to whether that actually does exist, quality of care. So the perceptions of nurses in this are really important. So again, just to kind of highlight, this is a recent slide, excuse me, this is a recent slide where we had a client ask us, you know, we know about nurses in magnet work environments. What about physicians? Is physician engagement better in magnet work environments? Now, having said that, whether an organization is magnet or not, okay, we know that those standards are ones that promote positive and healthy work environment. And so an easy way to look at that is to look at magnet organizations to kind of understand what that looks like. They've been accredited as that. And what they did find, indeed, is that physician engagement scores are higher in magnet organizations than non-magnet. So we know that the work that nursing does, because a magnet is all about positive and healthy work environment. We know that the work that happens that nurses do to create that situation definitely has a ripple effect beyond nursing. So the State of Nursing White Papers, when NDNQI was acquired, Christy Dempsey, our Chief Nursing Officer, was right on it. Have you met Christy? Anybody here yet? Yes. Okay, good. So I hope you do again in the future. She's like incredibly dynamic and has done amazing things at Press Ganey, and I'm sure before that as well. But one of the things that she did was started right away to do a deep dive into that data. And people ask me sometimes, why did you leave Press Ganey? I said, well, you know, why did you join Press Ganey and, you know, kind of leave the hospital and healthcare environment? And I said, well, I've spent many years, okay, being in a position to try to make, you know, the argument, okay, or the point, okay, about things that we need, resources we need, why practice and work environment is important, and so forth, with little tiny bits of data. Has anybody ever been in that position with Chief Financial Officer to try to make a point, okay, about something that you need, and you just feel like you don't quite have the data that you need, right? Or people might feel that it's soft. I'm here to say these cross-domain analytics, what we're trying to do is put in your hands, okay, information that's going to help you with those conversations. These are not little bitty pieces of data. These are big, big databases. And so what I say to people was it was time, and I had great and wonderful opportunity to be able to then move my experience in and have access to that data. Okay, so a lot of it's about asking the right questions. And so if you wonder like kind of how we decide what to do research on, we don't sit in a room and sort of just decide on our own. We have a Chief Nursing Officer Council, we have a Magnet Council, we have small focus groups. I mean, we talk to clients all the time to understand what the burning platforms are for nursing, and that helps us decide, okay, what we're going to work on. And I'm going to give you a couple highlights. I will send the papers back with the slides, and you might find it interesting reading. But 2015 answered that age-old question, how many times have you heard, if I just had more staff? Do you ever hear that? Every day, 2 hands back there. All right. I graduated from nursing school in 1978. What do you think was the #1 issue at the time? Nurse staffing. What is the #1 issue today? Nurse staffing. I worked at the American Nurses Association for 4 years. I was the vice president for practice and work environment. What do you think my main job was? Staffing. Okay. So staffing continues to be a real concern. And don't get me wrong, it's really important. But, okay, and, I should say and, that's a better way to say it. If mandated ratios, okay, and throwing more staff at things would solve the problem, don't you think we would have done that already? We would have done it if we had been able to make the argument. So we decided to look at the data and say, well, what's more important, staffing or work environment? And so here's what we found. This is like a very small snapshot, but an important kind of piece of data. So when you look down the left, okay, which is our perception of job satisfaction, quality in general, we said how important that perception is. As well as cross-domain, we looked at patient experience, okay, global measures like rate the hospital and some specific nursing ones like Nurses Listen. And then we looked at clinical outcomes for to remain in status of nursing, 2 big subscales of practice and work environment. Look how much stronger the correlations are as you move to the right. And so what that tells us is staffing is important, but the practice and work environment is more important. So if you throw staff at a toxic work environment, you're not going to achieve your goals. If that was going to work in California, those hospitals would be exceeding the nation in everything they do. And the results coming back from there are still mixed. And we believe they're still mixed because some have mandated ratios in work environments that are not good, and some have mandated ratios in environments that are good. So we see mixed results coming back. And so we need to make sure that we're paying such close attention to that practice and work environment because it has a much larger influence across most measures. Then we said, well, what about the work environment? And we did a paper on safety and surveillance, and here's what we found. That while surveillance, which is the ability to survey your patients throughout your shift, and basically the best way I can say it is to avoid missed nursing care. So while that's important, okay, that surveillance capacity is correlated with lower rates of hospital-acquired pressure ulcers, RN perceived miscare, and so forth. Look at the difference when you look at the nurse's ability to feel safe in their practice, that is, take safe care of patients, but also feel safe themselves in the environment. Look how much higher it is. So while both are important, okay, if you were going to focus on one to start with, it would be RN workplace safety, okay, because those are the things that correlate most strongly, okay, with outcomes. This is one of my favorites, probably because it was my first year at Prescott and I got to work on this one. And it's been a topic, of my heart, really, and passion for 10 years, is the impact of the nurse manager on nurse and patient outcomes. Is there anybody here that would say no to the fact that the nurse manager, unit-based nurse manager role is probably the hardest role in the hospital? Any nurse managers here, unit nurse managers? Think it's hard? Yeah, a little laughter, not so much, but it is hard. It's one of the hardest jobs in the hospital, okay? And probably, I think, arguably the hardest because of the span of control, what you're trying to do, the things that you're closest to. And so that's what we did the paper on. And the focus this time, we switched it around a little, was to say, what about high-performing nurse managers? And those were defined by nurse managers who had, they were in the top decile of how their nurses ranked them as leaders on the NDNQI survey. And they also were in the top 50th percentile, the top 50th, above the 50th, okay, for certain selected outcomes, okay, both nurse and patient outcomes. And so that's how we defined high performing. So, well, what do the best of the best do? And so this is what they looked at. They looked at nurse managers exerting influence on multiple variables in healthcare. And so the workforce environmental mediators that we talked about, those things off the survey, these might be familiar to you, these kind of categories: autonomy, professional development, nurse-nurse and nurse-physician relationships or interactions, components of teamwork, nurses' ability to participate in quality improvement, and staffing, and so forth. So these were the mediators of the workforce environment, that we looked at off the NDNQI survey. And then we had certain subscales that look at nurse and patient outcomes. So patient outcomes were mostly clinical, and overall, PX, patient experience rating. And then nurse outcomes were, because again, we said we're not going to look at one. We're always going to look at both, right? We have to look at that RN engagement and satisfaction to see, are we where we need to be? And so components of that survey were through the eyes of the workforce, which is a subscale that looks at joy and meaning in work. Really important component. There's been a lot of focus on that recently. Job enjoyment, which it's not exactly the same as joy and meaning, but it's related. Intent to stay, the most sensitive indicator of turnover, that we have today. It's been used in multiple studies. Perceived quality of care, again, we talked about that earlier. Nurses' perception of the quality of care in the unit, very strongly correlated to actual quality outcomes, and then missed care. And so these were the things that we looked at to say what kind of correlations can we find. And what we found is across the top there is all different kind of units: critical care, surgical, med-surg, rehab, emergency department, ambulatory, peri-op. I apologize in advance for those in women's health and pediatrics and other specialty areas, but we could only use the data that we had enough data to use that was returned to us, but it has implications for everyone. But what we saw was the nurse manager influence across all of those, significant, for almost every, it didn't matter which area, in almost every category. That nurse manager, that high-performing nurse manager had significant influence on all of these things. And that shouldn't, I don't think is surprising to most people. Then when we looked on outcomes, where did they have their influence on outcomes, those high-performing nurse managers? Eyes of the workforce, job enjoyment, and intent to stay are all indicators of nurse outcomes. And so we see that high-performing nurse manager, significant influence in almost all areas for nurse outcomes, less so for patient outcomes, direct patient outcomes. Why do you think that is? Why would a nurse manager maybe not have as much influence on direct patient care outcomes? Because they don't provide direct patient care. Their influence is on the staff themselves. So when you think about the breadth of that and the amount of influence they can have, so if you have a nurse manager, the average nurse manager span of control, 53 staff, and then you multiply that by the amount of patients they take care of daily, monthly, and annually, it's an enormous influence that they have, on nurses, for those nurses to be successful. And so a lot of that comes back to the nurse manager's main work, and their main responsibility is creating that work environment in which nurses can do and provide their best care. So these were the key points and findings, that they had substantial influence over the quality of the nurse work environment, and again, that direct impact on nurse outcomes and a little less so on direct patient care. And so really important, to understand, and again, these papers will come to you, but we just want to give you an idea of how we're using that data, to help you think about the work that you're doing, And so at the end of these slides, when you get it, there's an appendix of about, I don't know, another 20 or 30 slides that have pearls for practice in each of these areas, for each of these papers. So hopefully that will be of help for you. And then we talked to those nurse managers. We selected 12 and talked to them and did a qualitative component to say, so what do you actually do? What does it actually look like where you're working? And this is what they told us. And the one thing that you're not going to see here is I look at my data every day, or I look at it every week, and I make sure we set our scores. That's not what they were talking about. Number one, unwavering focus on quality and safety of care. They paid attention to creating a work environment, and looked at the quality of care, as their guiding, and the safety of care as their guiding measure. That's what they do. That's where they spend most of their time. Creating a culture of respect. We heard a lot about just culture. We heard a lot about zero tolerance for bullying, making sure workforce cohesion was high, really knowing their staff. Again, not to bring home to Thanksgiving or Christmas dinner, but beyond, you know how we talk about knowing your patients beyond just being a patient in the bed? This is beyond knowing the staff as a body that works on my schedule, This is getting to know somebody on a human connection level, and we're going to talk about that a little bit more in a moment. Interprofessional rounds and nurse manager support relationships, okay, which we just said. Interprofessional rounds and team building, very big. And they talked about, several nurse managers talked about having nurses leading rounds in the organization. In fact, one we did a paper on for we did a presentation at Magnet because they created a role called the attending nurse role because they were having problems with care coordination. It was Mass General, actually. And so they created this role. And they had a nurse Monday through Friday that led rounds on the unit. So that was physicians, you know, physical therapists, pharmacists, everybody. And then after that was done, they took all that information and made sure it got done, that the patient, you know, like whatever was brought up that day kind of went through. And so at the end of some period of time, 6 months or a year, when they were looking at outcomes, they did indeed have better care coordination outcomes, but they had an unexpected finding, which was on their RN survey. Okay, and their RN survey in the area, okay, of, you know, professional image and how nurses feel about their own professional image took off. There was a huge increase because they felt that nurses saw their value as a team member, not just somebody running in to give a report and going back. So that was an important, we did hear that from several managers, variations on that, but we thought that was really interesting. Huddles to improve communication, I think everybody's working on those. And then using data and evidence to support decisions in practice, but not in the way of numbers. When they're talking about data, they're talking about telling the story behind the data. Have you ever been in a meeting where somebody held up a row of targets, okay, and said, so, you know, we're at the 60th percentile, and we really want to be at 75th percentile, so we need everybody to get out there and kind of think about what's going on, and let's take care of that. What is the nurse who's receiving that information thinking? Are they actually attending to that, do you think? They're not. Why? There's no connection to the work that they do. This nurse manager, one of them talked to us, and she said that's not how she uses data. What she would do is, if she saw nurses that were in danger of burnout, okay, she used that data to actually pull patient comments out and then look at the scores and paint a picture of the importance of the work they do. And she would pull them in and talk to them and say, you know, I know you're having a hard time right now. This was in a pediatric, or I'm not sure, it was like a pediatric oncology unit, I think, somewhere like that. But they had a high rate of burnout, you know, a lot of compassion fatigue. And that's how she would use the data. Okay, she didn't use the data to set goals. I mean, they did have that because it's important to use it to guide you. But she used it much more effectively by telling the story behind the data. And so what I would say to all leaders in this room is that is something, if you're not familiar with it, something that you may want to work on moving forward. Okay, on how to best translate that to staff, because I can say to you, the further you drive that down, okay, to staff embedding that and understanding it in the work that they do, you cannot yourself as a manager or director or a CNO, okay, be pulling everybody with you. You need to have everybody on board. It's not going to happen all at once, but at least have it in your thinking, okay, as a framework as you move forward. How do we best relate this to staff so that they're working with us? How do we identify those champions who are early adopters, okay, and bring them with us, okay, on this journey and have them actually help us guide the journey? Safe and appropriate staffing will always be important, okay, but again, in the context of practice and work environment, we have to understand what that looks like. And then we know about the bundles of bedside report whiteboards and so forth, okay, which all organizations do, so they did bring that up as well. And then optimizing culture to improve RN engagement and reduce nursing turnover. This looked at across the generation, stabilizing the nursing workforce. And so, you know, we know that, again, burnout and compassion fatigue are still big. Staffing continues to be a concern, okay, high turnover and financial impact, okay, on constantly bringing new nurses in. How is your turnover rate here for new nurses? Is it what? It's not so good? Or and you would be along the lines of many in the country, okay? Right. So newly licensed RNs are at particular risk, and so we know what that does overall. And so there are specific things that we can do to attend to that. We're not going to get into all that, although I know we have some more opportunities for conversation after this, but there are things that we can do. And again, it gets into that practice and work environment and some of those best nurse manager practices that we just were talking about. Do you have a residency program for NLRNs? Okay. And so some of it, again, you've got the great vehicle there. It's just a matter of like revisiting perhaps and see where can we, you know, maybe make some changes and revisions. Key findings, strongest drivers for retention. Experienced nurses look for job satisfaction and joy in work, okay? Not surprising. You know, people want to go home at the end of the day finding meaning in their work. What does it do to morale, okay, when patient experience scores are low, okay, even though they're working their bottom off, okay, every single day? What does it do to morale? It's terrible, right? So patient experience scores it's not just the patient, it's also the caregiver. These things are, again, they're completely interconnected. And so when we strive to improve those patient experience scores, we are also going to be looking at improving our engagement, okay, and team engagement and satisfaction, because they're going to go home at the end of the day understanding this is why I came here in the first place. This is why I got into nursing, clinical practice, hospital work. That's why I did that, okay, because I wanted to be taking care of people. And if they're telling me I'm not doing a good job, it's a terrible dissatisfier. So, again, it's this flywheel that we have to pay attention to the whole picture. NLRNs, nurse manager support, is what they're looking for, join work and praise recognition. Now, my daughter is a millennial, okay, so she tells me a lot of things that I should make sure that I'm aware of, okay, in my work, and has no hesitation whatsoever to tell me what I should be focusing on, okay, when I'm speaking out on the road. And I listen, okay, because what she's saying is from the generation that's going to inherit this profession. So it's good. We have to understand where they're coming from in terms of what they want. And so nurse manager support, you all remember being a new nurse. What was your biggest fear? I'm going to kill somebody, right? Somebody going to come to harm because I'm not transitioned yet. I don't have my skills all down, and I'm working nights, of course, because as a new nurse, that's not uncommon, right? And so you may have less support on that shift and so forth. So they're looking for that nurse manager support, and the praise and recognition go hand in hand. They're not looking for somebody to say, attaboy, you know, pat me on the back. They're looking to validate, okay, that transition piece is happening and they're taking safe care of patients. And we need to pay attention to that. And they look at it differently than we did, okay, in generations past. When I came out, I'm a boomer, okay, and so you didn't talk a lot about those things, and you didn't look for that. You just basically watched the cues and signals, but you sort of kept it to yourself and internalized it, also bad, okay, you know, in terms of trying to figure it out. So it's a different response. But we should pay attention, probably healthier, to externalize it, okay, and look for that praise and recognition. Slap on the back, you know, slap on the back is not really what they're looking for. So they just want to make sure they're doing a good job. So key findings, top 5. We looked at, in this study, high-intent to remain units, and we did some additional analysis on those. And those were units that where 100% of their nurses said they were planning on staying for 3 years or longer. We said, what's the secret sauce there? Okay, what are they doing there? And so when we actually pulled all that out, these were the themes that we found. Again, they sort of relate to the last slide: quality of patient care, joy and work, manager support, tenured and experienced staff on the unit, one that we hadn't seen before. And what they're worried about is with this nursing shortage. Remember there was no nursing shortage until there was one? Yeah, so here we are again. This is probably the 4th or 5th time in my career. And so it's still, you know, not everywhere, but we're definitely seeing it. And what they're worried about in those places where they're seeing it is that they don't have enough. You usually have a ratio of newly licensed nurses, right, on a unit, because you don't want so many that we can't transition them to the profession well, and they're starting to see that ratio go out of balance. Too many NLRNs, maybe not enough experienced staff, so that came out as a theme. Workforce cohesion teams I'm going to come back to in a moment, and staff-driven scheduling and input on staffing. Do you guys do self-staffing here? Does it work go well in most areas? Okay. Yeah, and that's good, because that is a desirable thing. Nurses often want some control over their schedule. So those best practices that we see help them with their work-life balance, depending on how they approach that. The workforce cohesion in teams, interestingly, in the very large database of 250,000 nurses, basically correlated, when we saw high workforce cohesion in teams, was correlated with more likelihood to leave. And we did not understand that at first. That's the 245,000 nurses. And we said, what's that about? And so we actually ran that through with other experts, talked about it, and basically came to the conclusion, although we'd like to do a deeper dive with this to expand that work further. When you are in a very difficult work situation, there can be a very strong team cohesion. Okay, and it's sort of like a band of brothers in a difficult situation where they are supporting one another, okay, but it doesn't mean they don't want to leave. And so the reason that I bring it up here is if we see high workforce cohesion teams, don't assume it's because you have a great work environment. Okay, it may be the other way around. So you got to assess other components of that. And then the human connection, patients, families, and colleagues. So now we're going to just kind of get into the meat of it a little bit. Patient experience metrics, they're not a gauge of patient happiness. Anybody ever hear that before? This is patient experience stuff. It's about making our patients happy. Yeah. Okay, fluffy. It's not really important. Has nothing to do with my training, my ability to care for patients, and the things that I'm trained to do to save lives and heal and so forth. It's all these skills I have. Well, I'm here to tell you, patients don't care about that. I mean, they do. They assume because you're licensed that you have all that. Okay? And it doesn't really matter what we think. It matters what they think. Okay? Because at the end of the day, nobody in a hospital bed is happy, okay? There's no happiness in being away from your home and family and lying in a hospital bed and not feeling well and so forth. So what is it about the patient experience that we need to reframe our thinking, okay, about where we're going next, okay? And it really has to do how well we're meeting the patient need, not ours, needs for safe, quality, and compassionate care. And a lot of that has to do with the high anxiety levels that we see, kind of what they're worried about, the things that they're thinking while they're lying in the bed watching everything go on around them, okay? And they can be significant. And again, we know that we're busy, we've got a lot going on, we've got a lot of skills to bring to the table, but we need to go beyond that, okay, to talk about this. And so, not an eye chart test, just look down on your right, okay, in the green. See the green boxes there? Basically, this slide is just meant to convey what do patients really value. And this is outpatient, okay? Basically, if you see high confidence in the provider, okay, most of the time, very high rates of that, they will almost always recommend. So failure to recommend means only 1.9% will say they will not recommend, will be below the top box. So if they have high confidence in the provider, makes sense in the outpatient area. The next one below that worked well together. That's teamwork. So they're looking, okay, even in the outpatient area, they're looking to make sure we're all working well together. We're talking to each other. There's not failures in communication between team members, because what are they worried about if they see that? They're not talking to each other. Yeah, let me give you one. How many times, whether outpatient or inpatient, do we ask patients about allergies when they're under our care? More than once? More than 3 or 4 times? Probably. Why do we do that? Safety, right? We want to make sure that they're safe. Do we tell them that? So I'm a patient lying in the bed. First person asks me about allergies. Then somebody else comes in an hour later and asks me again. Third person comes in the next day. What am I thinking? They're not talking to each other. And who's going to drop the ball, and am I going to come to harm? So a quick switch in that conversation is, I'm going to ask you about your allergies, and you will be asked multiple times during your hospitalization for your safety. Does that change the conversation? Changes the conversation because we're thinking about it from their perspective, not from ours. We know we're doing it for safe care. We need to make sure they know. And then on the bottom, high concern for worries, okay, high courtesy, listen carefully to you. These are behavioral that are focused on the human connection. And so in the outpatient or inpatient, we see similar things in maternity, medical, and surgical. It's a little bit flipped, but you'll see similar. However, the big thing, when you look at that middle row, they're looking at high teamwork. Okay, more important even in the inpatient setting because of the nature probably of their illness, how anxious they are. They want to make sure that we are all talking to each other and the team is working well together. And across the bottom, the one that's added in here is different is room cleanliness. Why is room cleanliness important to patients? What are they afraid of? Infections, right? And so that courteousness, respect, okay, listen carefully to you, again, all components of human connection. And so improvement strategies are modeled, developed, are helpfully explained by a model created by Christy Dempsey and the research team here at Presque Isle that really look at all of the questions, okay, that we do on the patient experience surveys and bucket them into these 4 areas, well, 3 areas, caring behaviors, clinical excellence, and operational efficiency, so we can better understand how to react to them, okay? And so you can see at the top of that is caring behaviors. Those are the things that are very important to patients in terms of understanding this person knows me, they're going to take safe care of me. Okay, clinical excellence, also important, as is operational efficiency, but I'm saying to you that those caring behaviors are key. And so Compassionate connected care themes, okay, that came out of this research. So again, they pulled this out by talking to hundreds and hundreds of patients and caregivers to say, what does that look like, compassionate connected care? And what they came up with is acknowledge suffering. Okay, we should acknowledge that our patients are suffering and show them that we understand. Okay, a lot of that is done by what kind of things? Okay, in terms of body language, eye contact, okay, body posture, okay, some of that's in here as well. Our posture in talking to the patient, you know, whether or not, you know, there's some human touch involved, okay, asking them and personalizing the discussion with the patient. And, you know, body language matters, okay, so if you're standing behind a machine, okay, kind of taking notes and so forth, and not making a connection with the patient, okay, their anxiety level is going to be up, all right? It's not about making them happy. Okay, this is about making them feel safe and that you know what their concerns are and who they are. Okay, that's what this is about. Anxiety and uncertainty are negative outcomes that have to be addressed, and we know this from Maslow's hierarchy of needs. What happens when your anxiety level is up? What happens to your heart rate? Blood pressure. Can you start to perceive information coming your way about trying to prepare for discharge? None of that. It is our job, fundamentally, to get that patient's anxiety level down as low as we can. And we know that coordination of care is critically important, okay? We have to get patients ready for discharge so they're successful on their end. We don't want them coming back. They don't want to come back, okay? It's success for everyone. And then autonomy reduces suffering. And again, any way that we can help a patient with autonomy in their care, just small decisions, you know, do you want ice in your water if they're allowed to have it? If you're walking, do you want to go right out of the door or left? Whatever we can do. Always, again, behaviorally what you're moving towards is thinking about it from the patient's perspective. So it may take reframing of some of what you're already doing for interventions to think about that. And then caring transcends diagnosis. Well, we don't have time to do that today. I can send you information on it's an intervention that we call the 56-second connection. Has anybody ever seen this before? You've seen it, okay. And I can send you, all right, information on this. Basically what this is research has shown, because if you talk to a nurse about making human connection, talking to their patient, getting to know them a little better, what do they tell you is the issue? They don't have enough time. Less than 1 minute, okay, it's been proven that you can make a human connection. And so basically, you know, what this information will show you is that when you sit down, if you're going in to do an assessment, okay, and you use these kind of skills that we're talking about, you make eye contact, you start to just ask the patient a couple of questions while you're doing the assessment, okay, about why they're here today, you know, how's everything going, what do you like to do when you're not here. You're not adding on another thing. You are making it part of what you're already doing. Does that make sense to everybody? It's a behavioral shift that promotes and elevates the human connection piece to all those things we were just talking about. Putting ourselves in the patient's shoes, okay, making sure we're talking to them as if they're a relative. Like, what would they be thinking if they're a relative? What would I be thinking if I was lying in the bed? Instead of thinking as a clinician, because we usually go right for it, right? Patient comes on our care, we go in, so why are you here? What are your allergies? We get right to business, okay, because that's how we're enculturated into the profession and the work we do. We have to reframe that, okay, and do it from their perspective. And I would say, if you want one piece of low-hanging fruit to take away today, take this, okay? And we'll send information on this so you can see a little bit more about it. But I'm here to tell you, this alone, in terms of how all of you relate to each other, because you can use this with each other too and to patients, can fundamentally change the way patient experience happens here, okay, at Erlanger. So this is just meant to look at all of the things on key priority, HCAHPS priority index. Those are all with the arrows, behavioral. What's important to our patients? These are all behavioral. And you can see they're more than half, okay, of the key driver index items. And so best practice strategies, courtesy and respect of the nurses, okay, these are the things you're recognizing coming back to you, saying we want to improve in this area, communication, skill of the nurses, doctors, of course, is important. And then these are some other individuals, promptness in response to call lights. Anybody ever had the voice of God coming out of the wall? Yeah. Okay, and how effective is that? Patients, you know, just get rattled. So a lot of hospitals will use no-pass zones. Again, to emphasize, think about it this way. Everything is emphasizing that human connection. So instead of it coming out of the wall, there's a no-pass zone, human person stops in. Even if they're not the one that can fix the problem, they stop in the room to talk to the patient. Discharge, okay, cleanliness, we talked about already. We have to really kind of be thinking about that. And attention to special and personal needs and accommodations for visitors. And again, those ones are things that can very often, we're not talking about, you know, I don't know, like anything major like calling in, I don't know, valet service or whatever for somebody's needs. Sometimes it's just as much as, you know, kind of thinking about, could they use another pillow? You know, might need another blanket because they're cold. Stuff like that is really important to patients who have no control over what's happening. And they're also watching to see how we treat their family, okay? And so those are all important as well. Now, one of the things that throws people when we talk about this is we'll say, well, so how do we do all those things? We're going to talk about a way to focus it to one or two things to get where you need to go. But, okay, and you have to think about this as how often are we going to do it. In nursing, quality, when I was working in education, it wasn't unusual to set goals of, well, we'll try to get 80% of the nurses trained or 90%. And this one just shows if we train 90% of the individuals and 90% of the behaviors, like 56-second connection, if you do that or something similar, 90% of the time, the only thing it gets us is 73% of the expected delivery. That's the math. Where does that put you, do you think, in the Prescaney database in patient experience? In the bottom decile. So it sounds daunting, but whatever it is you decide to do, 100% of the people, 100% of the time, 100% of the behaviors, this is why you have to laser focus your efforts. If you're doing 15 things, you're never going to be able to do them all well. We're not saying you could take your eye off the ball on the other things, but you have to decide where is the laser focus that you are going to have. So that application in everyday practice looks at teamwork, room cleanliness, courtesy and respect, and listen carefully. 3 and 4 are behavioral. Room cleanliness we talked about, and teamwork we talked about. Now, you can see we're boiling this down, right? Do you do these here? Leader rounding, hourly purposeful rounding, and bedside shift report. How are we here with those? Those are 3 best practices that we see across the country and that we have looked at data and how that works. How's it going for you here? Any of these you think are better than the other? That's excellent. Okay, very good to know, and I'll tell you why in a moment. All right, how about the others?
We're working on hourly rounding.
Okay, purposeful. Okay. You're working on. So usually it's the opposite, so I applaud you, because when people say, well, which one should we start with, I usually say bedside shift report, and I'll tell you why. Okay, when you look at these 4 that you're trying to hit, think about bedside shift report. They have the opportunity to see, okay, team speaking and communicating well with one another, so long as the way that you're doing it brings in the human connection and the consistency piece. So if it becomes task orientation, okay, and it's not really done the way it needs to be done, that deeper dive in that human connection and behavioral piece, you won't see the results you're looking for. That's why you need to focus on 1 or 2 things and really embed it, okay, in the culture and practice. And you can do all 4 of these with bedside shift report. You're doing a scan of the, if you are thoughtfully creating, and I use script not as exact wording, but script as a general way that you're going to approach this work. Room cleanliness, courtesy and respect, and listen carefully to you. So the courtesy and respect and listen carefully to you, you're involving them in a discussion of their care. So if this is done right, thinking of these 4 things, okay, you can hit all 4. I would say that's the first thing I would go for, okay, in an organization if they're working on all 3. The other 2 are just as important, though, okay? And let me show you what we see. So in organization, this is a model of a 4-hospital system in the Southeast. Okay, they actually put forward what happens when we do these different interventions. And so the blue means none. They didn't do any of them. So they don't do very well. These are H caps across the bottom. If they add on hourly rounding alone, they see some improvement, but not anywhere much as you would like. If they do both hourly rounding and leader rounding, okay, you see that you get a much bigger increase in gain, and if they do all 3. So ultimately, one thing I will always say to an organization is you start with 1 or 2, okay, get them embedded, but you really ultimately want to look at all 3. Okay, these are the results we see, and we do see this in other organizations as well. When they firmly embed these practices, making sure it's not task orientation, and I'll give you an example. Hourly rounds, I had somebody ask me a year or two ago, and she said, we do hourly rounds all the time. I said, okay, so you do it, right? Yes, we do it. You do it all the time? Yes. Okay. How do you do it? And they all stopped and said, well, you know, maybe it's not, maybe it's somebody sort of poking their head around the corner and saying, hi, how are you? Just stop in and make sure you're okay. And she said, then we have this checklist, and then they sign it and come away. She said, do we need to keep the checklist? I said, is it helping you? She said, no. I said, get rid of it. No, I'm not saying that you should if it's helping you. But the thing is, keep in mind, when we do too much of that, those things are good for audit tools to get things embedded. If you use too much of it, it can embed in the mind of nurses and clinicians everywhere that it's a task, rather than the way we do business with our patients, the way we react and interconnect and intercommunicate or communicate with patients is really about human connection. So it's not that they're not important, but that's why we talk about it that way. So caring for the caregiver, you know, there's information in here for you to look at, because I think we're reaching the end of our time. And so I would just encourage you to look at these about the environment, things that you want to pay attention to. On the bottom here are things you want to eradicate. And again, some information on caregiver resilience. It's a scale that we do that you could always talk to Carrie about at some point if it's something you think you want to look at for your engagement piece. And then, again, key drivers of the engagement, it's always going to be, has been topped for quite some time by I feel like I belong. It's that human connection piece again, even for the caregivers. So important for patients and our caregivers. Same model, okay? And there's, again, some things at the end that will talk to you about, you know, ways in which you can think about maybe bringing some other practices in here. So does anybody have any questions? I know it's sort of a fast round. You know, talking to Janet sounded like you wanted, you know, sort of a general kind of overview. There's certainly room for more directed discussion, you know, as we move forward. Is there anything here that jumped out at you that you would change next Tuesday, okay, if you can? What would you do? What would you change? Bring on to your unit, yeah.
I think I would try and do more leadership rounds.
Okay.
We do some of it, but with all the other tasks that we have as directors, I think that sounds to me very, you know, a high important.
On both patients and staff.
Correct.
Correct, yeah. Very good point. What else? And we have a lot of resources we can share with you, okay, on how other organizations are doing this if you just want to see just how some others are doing it successfully. Anything else that you would take away? How do you feel about the human connection piece? Is that something that you think would be useful to bring back, maybe to relook at? And I'm going to say to all you leaders out there, don't try to do this by yourself. I will guarantee you that there are nurses on every unit here in this hospital that would jump at the chance, okay, to be involved in something like this, okay, because they're in it also, okay, to take good care of patients. They want to feel like they're making a difference. So start to encourage, if you don't have them already, identify those champions, all right? Make sure, as much as you can, they represent different generations. You know, you want some millennials, you want experienced nurses working together. We all have something important to contribute. But I would get those champions up and going. Anything else? Anything else that you would take away from this that you think you would like to try? Or you want to think about it some more? Okay, well, thank you very much. I know it's a little bit of a time limit. If you need anything, you certainly reach out to Carrie, who I didn't introduce, but Carrie is your regional director, okay, for Presque Isle, and she does all kinds of, like, incredible work here right now. Carrie Shuck.
Happy to help.
Yeah. Okay, thank you, everybody. It was a pleasure.
You're welcome.